Okay. Um, Hello, everybody. Very nice to see you here. My name is Lakshmi Narayan, and I'm the president and co-founder of Awake.net, which is an entheogenic social network and community for the. Our mission is to end addiction with Ibogaine, and we've been beating this drum for 7 years. And I'm in the process of making a documentary, Iboga Saves, and putting on events as much as possible to educate people. And my particular goal and mission in doing all this is to talk about bring together the scientific and the spiritual, the medical and the metaphysical, because I think the metaphysical dimension of healing with psychedelics is a really huge part of how the healing happens, and it's not talked about enough. I know there are other people in this group who really feel that the conversation right now is very much that Ibogaine is a magic bullet, and that we should let people know that there's a it's a difficult treatment, and there's things on both sides of it, preparation and integration and aftercare, that you really need to engage with your own healing in a very active way. It's not a magic bullet. So I want to bring that out in this conversation. If someone is coming on, can you just mute your iPhone? I think that's I just muted you. Okay, I just muted you. I don't know what your name is. Um, so anyway, that's the goal of this meeting, and so President Trump just passed this executive order on Saturday, which has really revolutionized the potential for what psychedelic medicine can do and what Ibogaine in particular can do. And I, for one, I'm very grateful and appreciative that somebody broke through, and now Ibogaine is a word that is on everybody's lips, national and international. And so, even if nothing else happened after this executive order, it has still made a big difference to all of us and to anyone who can be helped by it. So, Ibogaine, I'm just going to give you a short history of Ibogaine, and if anybody else wants to chip in and add something to that history, we can do that. So, um, Ibogaine is a extract that is found in many plants, primarily in Tabernathi iboga plant, which comes from Africa. It grows native to Cameroon, the Congo, Ghana, and of course Gabon and the Bwiti. Um, the the iboga, the psychoactive effects of iboga was the story that I've heard is that it was a pygmy couple shot a hedgehog, and then they ate it, and they got high, and then they found the wood in the stomach of the hedgehog, and they discovered that that was how that was what made them have an altered state, and then it became a part of the pygmy tradition, and they passed it on to the Gabonese, and the Gabonese and the Bwiti are currently the main holders of the medicine, and they've been holding it for a long time and have brought it to us. So there's a lot of that's a whole other conversation that we're going to have in the second panel. Um, then in 1962, Howard Lotsof, he was a drug addict in New York City, and he somebody gave him Ibogaine HCl, and he took it like a party drug, and he found the next morning that he was not craving heroin anymore. And so Howard Lotsof and his wife Norma spent the next 40 years campaigning to try to bring Ibogaine into the mainstream. And they didn't succeed. I mean, but they made a lot of dents in it. So, then other people have picked up the torch. And a lot of people in this room here who serve Ibogaine, I personally feel like these are like the heroes of the Ibogaine, pioneers and heroes of the Ibogaine underground, because they've had to take a lot of risks to bring the medicine to people because of the unregulated environment in which the medicine is served. And there are national boundaries you have to cross in order to be able to get the medicine. But we have a lot to learn from them because they've been doing it for so long. So I'm looking forward to hearing from those folks. So Ibogaine HCl is the extract, and it's different from the iboga plant, which has 12 different alkaloids in it. But ibogaine HCl is very effective in interrupting addiction and treating TBI and these other um, afflictions that veterans and so many people in the world are suffering from. Um, I would anybody else like to say anything about the plant itself, about the ibogaine plant? I mean, the iboga plant or ibogaine?
Yeah, it's a shrub. It can become a large tree, or I'm sorry, a smallish tree or a large shrub. It matures at 5 to 10 years old is about how long it takes to grow before it's like usable for medicine. 5 years minimum, 10 is better. There are trees that are at least 100 years old that are pretty big trees. It's got these interesting little orange fruit that look like peppers, which you can actually eat the pulp around the seeds. They're mostly just seed pods. And There are several different varieties of iboga. Some of them are hardly researched at all. There's the kind of like different, so who knows what variety of alkaloid content is in that. And yeah, that's just a little bit. It's just a really cool tree. They even use the sap medicinally in Gabon. So.
Yeah, so ibogaine HCl also comes from Vuacanga and Vuacangine, and a lot of people use that in their treatments. So there have been some questions out there about, oh, some clinics don't use iboga. Did you know that? And it's not really significant that they don't use iboga. In fact, it might be better for sustainability reasons because it's a big part of the Brady culture. But uh, Vuakanga and Vuakanjin can be manufactured. And Chris Jenks, who's on here, and Ian are probably going to talk about it later down the line. Thanks, Ian, for that. Um, so I'd love to talk a little bit about the actual ibogaine treatment for TBI or addiction interruption, because I know that that's what everyone is interested in. So, Gareth, would you be interested in talking a little bit about what you do? Gareth is the founder of Inner Realms in Tepoztlan, and he and Blair have been working with the medicine for decades, right?
About 14, or coming into year 14 now. I think I gave my first treatment to somebody 14 years ago. It was something done in Mexico as I was training. Yeah, yes, I can comment a little bit.
And feel free to share something about yourself too, about what you do and everything.
Yeah, sure. I got into this work through my own personal struggles with addiction. I actually recovered from alcohol use disorder almost 26 years ago with the use of LSD, which kind of sent me off on this path. Um, and so Yes, treatment. There's been a lot of talk recently, so if you've been listening to Bro Rogan, then, it makes it sound, there's been a couple of podcasts recently with Brian Hubbard and Rick Perry, and it all sounds a little bit too like a bit like a magic bullet, where he throws out quotes like 80 and 90% and stuff like that, which is not really true. With all recovery, it really depends on who you're working with. And we have found that over the years, our favorite group to work with is 30 or 35 and up. I can reflect back on my own personal experiences. In my 20s, the drugs and alcohol were working quite well, thank you very much. So, when we come up with percentages of what the, success rate and stuff like that is, I think it really depends on who you're working with, especially around addiction. Not with something like TBI, but particularly in addiction. And, it's very much not a magic bullet. However, I like to think that when we're working with people in addiction, the people I like to work with that have, kicked in jail, kicked here, been to rehab a bunch of times and stuff, because they really appreciate what it is they are getting when they come to Ibogaine. But having said that, it's not easy. It's not an easy medicine to take at all. for a lot of people. I'm not saying it's got to be a, horrible experience, but for many people, it's a lot like having a mirror put up to your face that you can't look away from. And then we get to see all of our imperfections and stuff that we don't like to look at, stuff that we don't see, but everybody else does. Um, so, it can be a bit of an arduous journey. And I like to remind people that the real beauty of Ibogaine often lies on the other side of it. So it's very powerful in its actions, particularly when we're dealing with opiates. It means that people can step off of opiates relatively pain-free. And with the opiate cessation, normally what comes with that is post-acute withdrawal syndrome, which can drag on for months, depending on how long somebody has been using and what kind of amounts that they have been using. Normally, the higher the amounts and the longer the time, the longer that post-acute withdrawal syndrome stage lasts. And Ibogaine tends to carry people through that period. So I never encourage people to frame their experience as they come out the other side because it's an ongoing thing. We are great believers in getting a lot of ibogaine into people, but of course you can only safely do that in a certain period of time. So, when I hear Joe Rogan say that, it's 2 days and then 80% of people and stuff like that, we get calls from, and now people are arguing with us because
Mhm.
we tell them it's longer than 2 days. And an opiate detox, a heavy opiate detox can be 10 days to 2 weeks. So, it can be quite a complicated process, but for most people, a very rewarding one, but it's not easy. So
May
that's
I ask you
kind
a
of,
question, Gareth?
yes,
Is
please.
well, I just these protocols are evolving right in front of us. Like, I mean, I don't know if you've worked with the SR personally, but
No, not as of yet. I'm
okay,
very curious, of course, anything that can help the situation because it's
yeah,
gotten really out of hand with the whole fentanyl and the fentanyl analogs and stuff like that. So, yeah.
yeah.
Can you talk a little bit about what happens? Like what actually happens when somebody signs up, they
Mhm.
come to your website, whatever, fill out a form. What are the things that have to happen in order for them to get to the Ibogaine treatment? And you said it's not just 12 hours, it's more like a week to 10 days. Can you talk
Yeah.
about that a little bit?
Sure. Well, normally people find us through whatever means, usually the internet or referrals or something like that. Um, I often will get on a call with people if they I like to set an hour aside to really explain the process because it's not just as simple as like sign me up, I'm coming on in and doing the thing, you know. Especially people in addiction, is this the right time? Is there enough stability? We don't want to treat somebody if they're coming from a very difficult situation and then we treat them and then just throw them back into that difficult situation, which isn't really the best way for people to be entering back after treatment. We often like people in heavy addiction to go to, especially opioids, to be doing some kind of aftercare afterwards. Um, Never with traditional rehab, because then they'd be rubbing shoulders with people that haven't taken Ibogaine and are in clearly two different places. Traditional rehab is cigarette smoking, drinking coffee, and talking war stories. Whereas, the appropriate aftercare, there's a few different places like Jevons Place or Centro Nerica, which is close to us, which allows somebody to sit and process whatever it is that's coming up from the treatment. And in many respects, the real work begins once somebody gets home, and yet there's a real sense of doing work while they're with us because of the nature of the work itself. It's often a deep dive into somebody's own psyche. So we don't take everybody just because they've got the money. We wouldn't want to take somebody if we don't think that they are ready. Of course, there'll be plenty of other places that will take their money off of them. But we need to do an assessment to see if it's even the responsible thing to do at the time to treat somebody, and what the plan is. You know, too many people are like, oh, I'm just going to go do the thing, and then everything's going to be great because of what I've read or heard, or do you know what I mean? I heard on a podcast. So yeah, it's not as simple as that. And so, but the process is that somebody, you know, normally fills out an application, then we review that, get on a call, and then see what the plan is. Meet them where they're at, basically, you know. So, and then kind of take it from there. So, yeah. Did that
So
answer
then
your
it comes
question?
to you. What's that?
Did that answer the question?
Um, did somebody ask a question?
No, I mean, did
Oh,
you
me.
ask me to elaborate? I just hoped I
Well,
elaborated well.
well, so I think people don't know what Ibogaine is. Many people don't know what a psychedelic is, what a psychedelic journey is like. Um, my experience with doing Ibogaine, and it was the Ibogaine TA, which is so there's several different types of Ibogaine. Love to talk about that. The TA and the Iboga, the total alkaloid, but that's what the TA stands for. But my experience was that it didn't last for just 12 hours. It lasted more like 36 hours,
Yeah.
the, the whole journey. So these are some of the myths out there that it's 12 hours and people think it's some inpatient, outpatient thing. It's nothing like a normal hospital type of
Don't understand
procedure
this. We
because
don't
it's what
understand. We don't have instrumentation for
can
any of
you
our cases.
okay, I just muted. Um, Hi Barry. It's nothing like that. And I think people who have never done a psychedelic or who have never done a journey like this, which is an inner journey, there is a great deal of preparation that they need to do to be ready for the journey, not just a detox, but even mental, psychological. I don't know if Anders is here, but if Anders is here, he could speak to that a little bit. We're going to go into that in greater length at
I
another.
don't think he can make it this morning, but he's going to be the next one.
Okay. So, so during the actual experience, I know that you have to have EKGs to make sure that somebody is physiologically able to do the ibogaine. So, can you talk a little bit about that? Like, what is that cardiac element? What is a cardiac risk, and how do you deal with it? And anybody else who's serving ibogaine who wants to talk about that, please let's bring that to the surface and talk about the risk and how the risk can be mitigated. Dr. Deborah Mash, I don't know if she's here. I don't think she could be here either. Um, says that the cardiac risk of ibogaine can be completely um, mitigated or managed. It's not something that. But if it's not managed, it's obviously a danger. And there's a lot of clinics out there who are fly by night clinics, so they're not doing everything they need to do. So for people who are looking for clinics, some of the things we're talking about, these are things to look out for when you go look for an ibogaine clinic. You need to make sure that they are doing an EKG and they're monitoring you throughout the thing, and they do blood panels, um, and have a fibrillator, know how to, or have an ER very close by. So could you talk to some of that? Maybe Barry or Gareth or whoever wants to.
Barry?
Yeah, I could speak a little bit to that too. After working, doing a lot of the manufacturing side of, the production side of TA and PTA, it's a huge risk that we don't have better oversight and better practice around the analysis that goes into selecting material that's going to be used for treatment. I think that there is a lot of bad bark and bad TA and bad medicine that's getting into supply lines that's causing a higher risk for clients. And I think it's something that needs serious management and to be looked at and taken seriously. I think the Jenks and others were talking about some kind of an analysis system that would provide a little bit of a profile. And I think that's incredibly sorely needed. Because I know on good authority that a large portion of the bark that's being sent to America and Canada and other places around the world is not the right material. It's not the right content. It doesn't have the right spectrum of alkaloid. So that's a risk. People are taking something they don't know what it is. They don't understand that substance in a fundamental chemical way. And I'm just going to say, I think that's something that we really need to tackle as a community. There needs to be more attention paid to the actual substance, the analysis, and the chemistry moving forward, I think, than has been, it's been taken for granted. So I'll put that forward and I'll let the discussion continue.
I agree with that. I wanted to just jump in, and I see Rachel has her hand raised, but I just wanted to answer your direct question, if I could, Lakshmi, which is, yeah, there's two major, I think, screening issues with Iboga and Ibogaine treatments. The biggest ones are, yeah, the cardiac screening, which is that Ibogaine prolongs the QT interval, which is a repolarization time of the heart. It there's like this big bump, which is the QRS complex and EKG, and then the little bump is the T wave. And Ibogaine slides the T wave over to the right, this repolarization of the heart. And if it begins to intersect with the next QRS complex, then it leads to a condition called torsades de pointes, which leads to cardiac arrest. So many medications prolong the QT interval. The big problem is if someone has what's called congenital prolonged QT interval syndrome or congenital long QT syndrome. So if they already have a long QT, then prolonging it further increases this risk, or combining it with other medications increases the risk of torsades de pointes, which is cardiac arrest. Also, if a person has pre-existing arrhythmias, then that can be an increased risk factor. Most of this can be addressed through comprehensive cardiac screening. So those are the big cardiac issues. Uh, Another major consideration is that there are different metabolizer speeds of people. So there's this enzyme, CYP2D6. And so some people are um, poor metabolizers or fast metabolizers. And if they're a really poor metabolizer of CYP2D6, then the enzyme metabolizes the ibogaine more slowly, so it passes through the liver, and they end up getting a much higher dose of ibogaine, and it takes a lot longer to process it. So this is why there's a blood panel. One of the reasons is this CYP2D6. And then, of course, I just wanted to mention that another big aspect of screening is drug interactions, because ibogaine has some of the most complex pharmacological interactions of any drug ever. It interacts with at least 12 different receptor sites. So, traditional classic psychedelic mushrooms or LSD might primarily work with one receptor, like serotonin 2A receptor, whereas ibogaine it's a serotonin transport inhibitor, dopamine reuptake inhibitor, interacts with NMDA, nicotinic acetylcholine, sigma 1 and 2. It's got the incredibly complex pharmacodynamics, which is why screening is extremely complicated, or at least if people are on different drugs, you need to have a really complex, like a deep understanding of the pharmacodynamics of these interactions. So this is screening, and ibogaine like this is absolutely critical on every level. There's a lot. One more thing I'll say is that sometimes, I've heard people say you want to get off of all drugs before being on ibogaine if you're doing a detox. Well, sometimes it's the opposite. So like with benzodiazepines that interact with the GABA receptor, you actually don't want to be detoxed completely from the benzo, at least on a short term, because benzo withdrawals can be very prolonged and then reduce the seizure threshold. So if a person tries to quit the benzos so they can go do the ibogaine, then they actually are at an increased risk of a seizure if they do it too quickly. So the Gita protocols, for example, talk about actually switching to a short-acting benzo and then staying on that through the course of the Ibogaine treatment because the one receptor Ibogaine doesn't interact with is the GABA receptor. So this is all just a quick overview, but it's just to give you an idea of the very complex. There's enzymes, metabolization to consider. There's lots of cardiac stuff to consider. There's epilepsy. Yeah, sorry, Toby, I might have said that wrong. I'm sorry. I meant to say switch to a long-acting benzo. I apologize. Thanks for catching that, Toby. Yeah, and yeah, I misspoke there. Just to give you an idea that you can't just, do a simple screening. It's actually a lot more complicated. Anyway, I know Rachel had her hand up for quite a while, so I just wanted to stop
Thanks,
there.
Ian. I'm gonna combine a couple different things. In support, Gareth, of your original comment about when you and Blair like to work with an aging population, like I heard the age 35, and as a former college professor, I can really identify with that. The older students who came into the classroom at age 40 after a career were way motivated to be there. They weren't just swimming with the school. That being said, I started writing in a comment when I first was introduced to the world of Ibogaine through a former loved one. Ben Delonen's film Rite of Passage had just come out. It was a documentary with lots of sort of ethno-historical work in Gabon. And so in that film, the initiation rites, as they're used in the Bwiti and Masango traditions, I think are at an earlier age. Also in that film, there was treatment of a woman who had a really bad postpartum depression and couldn't get out of her sort of prolonged grief. And she was nursing during the village ceremony. I bring those sort of long ago examples up to remind us all that I think what Christopher Lawrence would call the medical cultural technologies in Gabon in the ritual village context, those have a lot to offer to what moves forward with Ibogaine treatment. For example, maybe some of the early fatalities in the treatments were because there wasn't drumming, and that drumming in the circle actually helps a meat puppet stay in its heart, or that at certain points in an African ceremony, because of the experience of the people who inherited the use of this plant, they're aware of all sorts of subtle, energetic things, and they grew up around it, right? They're not just sort of jumping into it. And so there's a whole group of people, and at a certain important point, music is played, and it's like a harp on the head, breaking open the head, to use Daniel Pinchbeck's metaphor. And these are also important in terms of considering the cardiovascular risk and the way that the interruptive model that Deborah, Dr. Mash, and Howard, and other people who maybe are no longer in the field were trying to advance with the FDA in 1994, that interruptive model was pushed aside for a substitution model, namely Suboxone or buprenorphine or whatever. And that ends up creating complications now in terms of what treatment possibilities exist in the United States, even in trials, because buprenorphine is a QT prolonging. It's a substitute which someone would have to take for the rest of the day, the rest of their life, or for some period of time before they tapered off of. And methadone, which is maybe more also widely available, and it is a very hard on your QT prolongation. The first treatment I was involved with was a person who sort of heroically did a major series of flood doses, unmedically supervised, in like a medical vigilante setting. And he had been on methadone for maybe 7 years. And he tapered down from 80 to 50, did not have a short-acting opiate swap. No one would ever, no responsible provider now would ever do that kind of treatment. I think it ended up being like a 36 milligrams per kilo dose over X period of time. And because there was a lack of clinical data, and at that point in time, 2004, there were references to like a vast uncontrolled experiment taking place in motel rooms, and I recorded all the data, and sort of live streamed it on an old list that Patrick Krupa had. So this interruptive model for drug treatment, it's great that the narrative's changing on it. It's complicated, although to go back to my original point, I think, Gareth, to exclude anybody under the age of 35, I would think that an 18-year-old drug user is going to have a better heart just at baseline, than I do at 57. And that even actually helping people who are in addiction at an early stage in their trajectory could save a lot of harm. I work in my own research in women's health, and I think of teratogenic harms to children in womb. At a certain point in the last 5 years, I had someone say, well, would you recommend Ibogaine to, people you most loved? And at that point, the addict in my life was very young, but she had an acquired congenital heart defect from being exposed to methamphetamine, which she was in the womb from her mother. And so I couldn't, I didn't feel like I was the best person to say, yeah, try Ibogaine instead of fentanyl, because I knew she had a cardiac issue. So the cardiovascular risk is real. I think it's significantly minimized when taken in the appropriate medical container with an IV in place. So in the rare possibility that there is any kind of cardiac issue, atropine can be administered like that quickly. There have been deaths that could have been avoided if there had been proper medical care, and that it has applications also for brain injury and other neurological issues, which I think also might affect pediatrics or high school and college athletes. So I just wanted to offer that back to what age. With one more note, if you're a parent with a kid living in addiction, it's a hard balance, to offer this, and you can't really push it. Someone has to be ready to recover, and so that sort of goes back to Gareth's original point. 35 and older, they've partied out, they're ready to get off the roller coaster. It's harder to tell a 16-year-old or an 18-year-old to change their life. Thanks.
Yeah, exactly. Thank you, Rachel.
Thanks, Rachel. Yeah.
So Tobias is in the room, and Geeta is the co-host. So I wanted to invite Tobias to say hello and talk to us a bit.
Hey, Toby.
Hi there.
Hi, Toby.
Can you guys hear me?
Yeah, but we can't see you.
1 second. I'll just rearrange a bit. Okay. No. Wait.
Yeah, okay.
Hi there.
Hello.
Yeah. Hi there from Oslo. Currently here in Norway. Yeah, it's very spontaneous that I'm part of this here now, and I'm currently mainly involved in microdosing. So to say, guiding people remotely for Parkinson's disease, but also for depression, anxiety, and general mood stabilization. Used to do a lot of full flow treatments, but nowadays the microdosing or the possibility to have a broader demography access this medicine is with microdosing much easier for a lot of people because, for example, Parkinson clients are a demography which is generally in the older ages. Like now it's getting younger, but usually they are over 60, 70. And for them, like having a potentially lethal near-death experience is not necessarily really appealing. So we were looking into ways on making the beneficial side of Ibogaine accessible to a broader demography, where the midi dosing, microdosing, and subflots are a pretty good way to go. So that's pretty interesting what's possible there. But I'm not sure how deep I want to go now into that. So maybe I open up for other people, and if there are later questions regarding what I'm currently working on, I'm happy to answer anything.
Thanks, Toby. So Toby, your work with Parkinson's is, I'm sure, will be of interest to many people. So maybe down the road you can talk about that a little bit, if you want to go deep into it, or even more than you have. Um, I think people would be very excited to hear about it. And so let me just hold on.
I see Jimmy's got his hand raised. Maybe that's a
Oh,
question for Toby.
yeah. Hi, Jimmy.
Hi. Yeah, so I'm here with my business partner, and we're in Chico, California, and we had been administering a microdose tincture to his grandmother with Alzheimer's, or it's excuse me, she has dementia. It's I'm just curious. I personally don't have all the experience of seeing many patients through that particular lens, and I'm curious if anybody in the group, maybe Ian or the gentleman who just spoke, could talk about some of the treatment processes for those kind of patients and kind of the results and the length of time, and just anything would be great as we're trying to help this wonderful woman. Thank you.
Sorry for asking quick. How were your experiences now with dementia in general? Because I mean there are different forms of dementia, and usually Ibogaine has this, or different Iboga alkaloids have this really beneficial effect on the dopamine metabolism, specifically on the dopamine transporter and dopamine reuptake, but also this neuroregenerative or neuroplastinogenic part of on dopamine neurons. And for example, Alzheimer's or other kinds of dementia are more globally. Parkinson's is very specifically in the motor neurons and the dopamine neurons of the substantia nigra and the striatum, where luckily Iboga also works specifically there. On other forms of dementia, they are more broad, more globally. So I'm curious how your experience were with treating general dementia.
Yeah, we haven't seen all that much improvement. At the same time, it has been a little bit difficult to keep her taking it, right? She is at an old person's home, and we're definitely just doing our best to make sure she's trying to stay on it. Maybe minute improvements. Would you say that, Jeremy? I'm asking my partner right now.
It just hasn't been something that we were able to administer on a daily basis. So it's been very, what's the word?
Sporadic.
Sporadic, yeah.
Yeah.
Mhm.
So maybe it's
So as
more
a
kind of
general thing, what my experience is that if you have a continuity with microdosing, we have the best results. So it's things like the Fadiman protocol also might be super great for psilocybin, but specifically for Parkinson's patients, it has proven to be most beneficial to have a daily intake and continuous to kind of keep this neuroplastinogenic effect height or on for a duration of time, not going in an up and down, but having this continuity.
and so how long is the recommended period? About a couple of months, or has anybody treated anybody with Alzheimer's or dementia before and had some good success? Or that's more so what I was curious, just to see if anybody's already kind of done that in this group or not.
I did have been doing a little bit of work recently with older people that had come in for brain health. A couple of ladies and an older gentleman, and I have an older gentleman with me right now, all in their 70s. The first group that we worked with had a very positive thing come out of the work. We just worked with Iboga in relatively low doses, but building that up a little bit over the week. And then afterwards, they continued with working with tincture. And there was just a sense that a couple of them in particular seemed to have more clarity, and so that kind of sense. None of them were really displaying the signs of dementia, or not more than the kind of decline that we all start experiencing at 40 or something like that. So it was interesting because, I always like to say that the majority of the people we work with, when they come to us, they're not whistling Dixie, but this group was, and so, but they felt that they got quite a bit of benefit out of that. And, and we're working with a gentleman at the moment, which is he's dealing with some childhood and some work issues as well, come with his wife. And so it's a slow process, but I'll have him doing tincture afterwards as well, or some low dose, and then we'll be waiting for the reports around that. So just the limited amount of stuff that I've done so far there's been quite positive feedback from that, and it's all been with Iboga, not really working with Ibogaine. So yeah.
Thank you.
Welcome.
There's an article about patient D. I'm going to see if I can pull it up. But patient D he's dead now, but he microdosed Ibogaine for Parkinson's for a long time. And I interviewed him, and it made it definitely made his life much, much better with Parkinson's. It didn't get rid of the Parkinson's, but it managed the nervous system and made him more comfortable. So I just wanted to offer that. It's not dementia, but it's a neurological disorder. Yeah, put the link.
Patient D, I remember gave a talk in an event in 2015, and it was really quite moving. I apologize we never got the video. One of the things I remember about him describing the impact of Iboga on his symptoms was he could his hand wouldn't shake bringing it up a soup. He could drink soup again. And his son has recently published a memoir of that. Patient D worked for a long time in alcohol recovery in the Santa Cruz area, and is from an interesting family in the longer hagiography of countercultural psychedelic warriors.
Right. So can we go back to talking about the Ibogaine treatment, the clinical treatment, and this idea of it being an interruption, and that it's really like the first stage of somebody who's interrupting their TBI. I guess it interrupts TBI too, but it's the first stage or the first major breakthrough in a journey of healing. And this is why people talk about integration as being so important, because there's this one big shift has happened in your brain, which is miraculous. Honestly, it's a miracle that a medicine can do that and break through such a persistent thing like addiction or trauma, or TBI or other brain things. But after that happens, you go home, and this is actually true for anything, not just people who are in addiction. Anybody who does a major psychedelic journey is going to go home and is going to need to integrate that into their life in some way or the other, integrate their insights or change their behavior. It's not just for addicts, but for people who are in addiction, it sort of starts to unfurl something, and they have to make some serious changes in their life. And it's not easy to change your patterns. We all know that, whether you're addicted or not. So could somebody talk about, Barry, could you talk about, like, how do you deal with that right now with the people who come to you for addiction? Like, how do you deal with, like, what do you send them home with? And what happens to them after they get back?
Well, first of all, before they even come to see us, we review with them what kind of support mechanism they're.
Oh, sorry, Barry. I accidentally muted you. Could you unmute yourself? My fault.
Am I unmuted?
Yeah.
Yeah, sorry about that.
Oh, all right. But the process begins before people arrive. And in assessing the application and being on the phone with them and usually having video calls, we try to understand what kind of support mechanism they're going to have afterward. And we will actually decline patients who don't have the understanding that this is not just going to be a magic bullet. And uh, the whole matter of aftercare takes a lot of different directions. Sometimes it's just making sure that they have a ongoing connection with a member of our team, or if they've had a coach before they've gotten here, to make sure that they are committed to continuing to work with that coach. The difficulty that we have is with aftercare centers. In Mexico, we had been working for the last, well, decade or so with Inscape Recovery, who has now gone out of business. Um, and one of the reasons that we particularly liked working with them was because they were in Mexico and pretty qualified for their aftercare. They were also able to administer small doses of Ibogaine for the advent of pause. And the aftercare centers in the United States that we've worked with, and many of them have been, well, the few of them that we've worked with have been extremely good, but they have run into that problem. So sometimes it's encouraging people to do a 12-step program. It's not unusual for us to have a addict here who will go with one of the members of our team to a an well a you know a 12-step program here to introduce them to it. But it's a little bit difficult because here in Mexico, the sessions are usually in Spanish, although that's not true up in San Miguel de Allende and maybe a couple of other places. But having the ongoing aftercare is a issue that has its complications because of what I was just mentioning about them having real knowledge about Ibogaine and dealing with somebody who is coming off of long-term addiction. But to go back to the beginning of what I was saying, and that is that we don't accept a substance interruption uh, process unless we are assured that they are committed to some kind of aftercare support.
Yeah, that sounds like a wise thing. So Barry, can you talk a little bit about iBurgerQuest? Barry has been doing this since 2006 and has a very really wonderful group of people and process that he employs for people not just with addiction but also with working with psychospiritual, right? You take both groups of people at the same time, or TBI or whatever.
Well, if I understand your question correctly, Iboga Quest is a little bit different than than most of the other models. I don't know all of them, but we only have one session a month where we treat 7 patients at a time. And I mean, we find that there's an awful lot of work to be done prior to and post Ibogaine. We stay in touch with our patients. So we do combine the substance interruption patients with people here who are here for psychospiritual. And it's really terrific when the people who are here for psychospiritual or for some kind of mood disorder, when they see what somebody else going through addiction interruption is going through in the process, they are really amazed. Now, Ibogaine treatment in our process, we administer Ibogaine on two occasions, usually 3 days apart. And the instances where individuals come from the substance interruption world, they are so remarkably changed that it encourages the people who are there for other reasons to be sometimes just blown away by it. Um, we are very heavy on the psychotherapeutic element of the Ibogaine experience. And so all of the people in our group have some psychiatric experience, or and they are assigned to a patient is assigned to one of our individuals, and assuming that there's a feeling of compatibility, we can always change the arrangement, but that we have the connection with them both before, during, and after. Um, I'm not sure what else is pertinent to be saying at this point. Do you have any particular question, Lakshmi, or
Well,
anybody?
anybody? Well, I have a question about do you have people come in for addiction who are veterans or yeah, who are veterans basically? Do you have people come through in your group from time to time?
Oh, absolutely. I
And
know,
then
and way before the Stanford study, we had been treating not a lot of people, but uh, certainly at least a dozen or more of people who had military traumas. And in every instance, there has been improvement. I can't go to the extent of what Nolan Williams was able to do, where they were doing MRIs before and after. But in terms of the traumatic brain injury, um, the PTSD, but it was also very often combined with usually alcohol. Sometimes it would be with um, uh, cocaine or methamphetamine. Very rarely, I don't think we ever had a patient, a military patient, who was also using opiates. But so we are treating both of them simultaneously. We often will have our program runs 8 days in general, but it runs up to 13 days. And we will often have people who are dealing with substance as well as with psychiatric problems come in several days earlier for preparation, and to, well, in some instances, do multiple electrocardiograms and repeated tests, and moving them away from their substance upon what we're talking about, but a certain period of time, usually going by the Gita guidelines, to be you know, succinct about it. Although we've learned that since the initial Gita guidelines were published, we've learned enough since then, and need to assess how long they've been using and how long and how much they've been using, and that will depend. It will it will influence how long we want to have them here prior to doing the 2 doses of Ibogaine. And we use Ibogaine strictly. And I know that, I just heard Gareth talking about him using Iboga. But we have found that by using Ibogaine, we're able to measure the dosage much more precisely. When in our earlier years, when we were using both PTA and TA, that each batch would be so different, one from the other, that it makes us hesitate to use that protocol.
Hey Barry,
So
I have a question, and Lux, is that okay, Lakshmi?
yeah, absolutely.
This was a question that someone just asked for you. Uh, they asked, they were curious if depression and addiction can be treated concurrently. Uh,
Yeah.
yeah, so that's just a question for you from one of the guests.
Well, the answer is
Basically,
absolutely. In fact, I mean, our view, my personal view, is that when we're dealing with substance abuse, it almost always has an undercurrent um, of mental problems, PTSD, maybe even before cognition. And it's not us that does it. I mean, we're here to support, but the Ibogaine, and I'm sure that all the providers here can verify this, that a lot of material comes up that people are completely astounded by, that they had been experiencing and living with the emotional aftermath of situations that they've had that are not even a part of their memory. So I'd say that we are always dealing with the psychotherapeutic element of it, whether it be somebody here for PTSD or for addiction interruption. The two of them go hand in glove.
Right. Um,
thank you.
Thank you, Barry.
Does that make sense?
Yeah, yeah.
Absolutely. That's kind of was my interpretation too. They have the same root cause, and Ibogaine, like Gareth originally said, holds a mirror up, and people don't just randomly get addicted to things. Often it's an effort to self-medicate and treat
Right.
depression or some kind of PTSD. And Ibogaine has a neurological effect of interrupting certain types of addictions, but it also always seems to have that psychotherapeutic effect. So it addresses the root cause of all of the issues, to my understanding. Yeah, thank you.
I concur.
So that's the major difference between uh, Ibogaine and other all psychedelics make you can have a really big journey with psilocybin, 5 gram journey with psilocybin or an ayahuasca journey, and you can have a massive, massive experience. And many people have managed to end alcohol addiction with psilocybin. And I don't know if you've heard this, but I've heard more than one person say that the reason they were able to what happened to them in the psilocybin, which is what happened to me, is that it they realized that when they smoked, they were a partner of death, or drank alcohol, and that they didn't want to be a partner of death, and so they became a partner of life. And so this is the psychological shift that psilocybin, for example, gives. So my question to you, Barry, is really about was kind of a little bit more complex about, so when you have veterans come to you for addiction, and veterans come from a background of discipline, and suppression, and then when you have somebody who's in regular addiction come to you, and I find that people in regular addiction who are in fentanyl or opioid addiction are often unable to follow through on stuff. They get sucked into their addiction cycle, and this has been a real problem with intake, etc. So do you see a difference between these two types of people who come to you? And is there something that can be learned from a veteran's approach to it, is there a difference, I think is my question, between these two um, kinds of patients?
That's a hard question to answer because each individual reacts to the medicine differently, and the history of the individual and what caused um, uh, their interest in doing Ibogaine, it differs so greatly. I would say that we will look at each individual and not necessarily categorize them as the PTSD being a cause of a military action or a first responder action, and somebody who had a sexual abuse in early childhood. Um, the individual is what we're looking at. We don't have a codified particular protocol that differs one from the other. In general terms, it's on an individual basis. So, I understand all the interest that we have in the military. Of course, it's overwhelming the news these days. And the outcomes that we have had dealing with people with severe PTSD have just been so overwhelmingly positive. And I can't differentiate between the military route and other elements that might have caused the traumatic um, the traumatic instance that has caused them to look for substances. I don't want to get complicated on this. I just want to say that I would rather look at it as on an individual basis than categorizing people according to how they wound up having the difficulty they're confronting.
Okay, that sounds good. Um, I know that Ian has a question for Gareth, but I just want to ask one more thing. If you can, you said in your comment that people, when they take the Ibogaine, they will have things happen that they just are totally surprised by what comes up. Can you give an example of something like that? Of course, if you can, just a general example.
One of the regrets that I have is that through the years, I haven't codified or I haven't archived some of the outcomes that people have experienced that were not even on their radar when they came to do Ibogaine. And this happens in almost every single session we have. Uh, Sometimes it's very often something that's physiological. We've had people who have come in here to do work for psychospiritual, but they have had a shaking in their hands shake on a perpetual basis and or intermittently and find that they don't have it. In this last session that we had just last week, we have a woman who has chronic nosebleeds. And now we're only talking about, I think, 8 days ago now, but she has not had a nosebleed again since she's done the Ibogaine. We have had people who have had chronic pain. They were not coming here to address the pain, but they'll come and after the Ibogaine saying, wow, my leg doesn't hurt anymore. This is a place that an awful lot of research is still due. And again, I'm kind of disappointed in myself that I haven't made note of this now going forward. Beginning probably about a year ago, we now are making notes of these unexpected outcomes that are experienced on a somewhat regular basis.
Thank you. That's useful, interesting. So Ian, did you want to I think you have a question for Garrett.
Sure. Sure. Someone asked in the chat here, and Gareth already answered in the chat, as did a few other people. But as this is for people who are new to Ibogaine, might as well ask it directly. Um, the question is, a big issue that's happening right now uh, is 7-OH, which is an extract, semi-synthetic extract of kratom, and it's a big problem. They call it gas station heroin. It's very addictive. It's so how effective is Ibogaine to treat this major issue that a lot of people are facing, 7-OH, 7-hydroxymethionine?
Was that to me?
Well,
Yeah, that's primarily to you, Gareth,
I
or
think
anyone
that
that wants to answer.
Barry and those guys have a lot more experience of that than we do. But we have been treating kratom over the years, and interestingly enough, with kratom, when and because kratom and 7-OH will prolong QT, so it's not like people can just show up and do a detox straight off of that. You normally have to intervene with a short-acting opiate that then will allow for a period of washout before we go in. So we normally use morphine, and it was the same with kratom as well. And just with kratom, and not the concentrated form, that we would often find that for every gram of kratom is 10 milligrams of morphine to hold somebody. And people are quite shocked when, I'd get on a conversation with them and they're going, yeah, I'm using about 30 grams a day. And then I'd say, yeah, well, I'm going to have to stabilize you on about 300 milligrams of morphine. And people are shocked when they hear that. So, so the 7-OH is another kettle of fish. And that concentrated version, I have heard of people using that stuff and then needing to be stabilized on as much as 1,500 milligrams of morphine
Wow.
in a 24-hour period to stabilize them for something they've been buying at the gas station. I don't think anything should be banned, but at the same time, like there definitely needs to be some education out there about what the fuck people are getting into. A lot of people that got into kratom, some influencer told them it was good for working out. And here they are now with an opioid problem.
yeah.
So people really do need to get much better informed about things before they start taking them. But anyhow, that's my 2 cents on that. Yeah, I think Barry and those guys have been dealing with the 7-OH, but much more than we have. We don't really have a lot of experience with it.
Well, I need to plead guilty to one of the things you're recommending there, or you're suggesting there, Gareth, in that there was a time where we would um, be dealing with somebody, say, who was on fentanyl, and and recommend that they switch to kratom, and there were a couple of instances where that actually did work, but it took a long time. We're talking about a couple of months before they were able to, um, and then be here to do short-acting opiates for perhaps 5 days, although it varied, before we would be able to administer the Ibogaine. The 7-OH is a horse of another color, and we are working on a different protocol right now with the SR 17018, where they will go for a matter of a couple of months using the SR to taper down from the 7-OH until they can be switched to a short-acting opiate. It's a very imperfect process. I'm not here to advocate for it. We're still very much in a learning curve on it. But that's the world that we're living in right now, where even, when almost any street drug is being used, we don't want to treat them until they have had that substance actually um, uh, investigated, and we know what it is, or know that it's something that we don't know anything about. People buying things on the dark web. But the kratom and the 7-OH is really a monster. The first time it was successful, but the first 7-OH person we treated, they needed to come back here twice and go through the full process. And we also had a preliminary process of using tremendous amounts of short-acting opiates, usually oxycodone, but also morphine. And the person left here and and went home, and things were looking really well. And then a level of pause, or I'm going to call it pause, but something happened where they were taken all the way back and could not resist going back to the 7-OH. And luckily, we were able to get that very quickly and get them back in. But very few people can afford to do that in terms of time and in terms of money. So we're putting great deal of our focus into looking at the protocol that I mentioned with the SR 17018 as a device for tapering off of the 7-OH before they can be switched to the short-acting opiates and then being treated with Ibogaine. It's a very imperfect situation. Hopefully, we're getting better at it. We're being very, very careful. We're working with somebody who knows an awful lot about the SR, giving us an awful lot of support. And it's one of the difficulties that I think most Ibogaine providers are probably confronting these days with unknown substances, but particularly the 7-OH.
I was wondering if I could jump in here and just talk a little bit about SR just for a second, for people unfamiliar. Is that all right?
Sure.
Oh, please.
Yeah, so SR 17018 is this atypical opioid that was synthesized by the Scripps Institute, and it's shown a lot of promise. It actually has this paradoxical effect of reversing opioid tolerance. So people are having a lot of success right now, basically kind of like substitution therapy. They just switch over off of whatever their opioid of choice is to SR 17018, and then they can stay on it for a matter of weeks, and it actually reverses their dependency while they're taking it, and then they can do a quick taper off of it and actually often stabilize off of an opioid completely, and be kind of clean for an amount of time. And then an ibogaine treatment is more effective. It's been a game changer. A lot of people are successfully tapering off of opioids just using SR 17018, including you name it, fentanyl, Suboxone, methadone, all of the opioids, kratom, 7-OH. So it's pretty new protocol, but it's really opening the door to, for one thing, it seems less necessary to do a high dose of ibogaine as a acute detox. So it's just a good example of how the protocols are evolving right in front of us. So ibogaine has been really miraculous for interrupting opioids, but I know some of the facilitators we actually talk about, oddly enough, the good old days of just heroin, because ibogaine is extremely effective for an acute heroin detox. But when people are dealing with these QT prolonging opioids like Suboxone and methanol and kratom, it's just a lot more complicated, and they have to usually switch to a short-acting opioid like morphine or hydrocodone for 2 weeks to kind of flush the other drug out of their system. And then ibogaine is very effective for an acute detox of morphine or a traditional opiate. But using the SR, we can actually taper them down completely before the Ibogaine treatment and requires a smaller dose of Ibogaine. Although the other side of that too is, as Gareth would talk about, it's really helpful to actually load them up with a lot of Ibogaine because over a period of time, because the metabolite of Ibogaine is noribogaine, and that is in detectable amounts in the body for 3 months after an Ibogaine treatment. And that's a window of time we call the pink cloud because for about 3 months after an Ibogaine treatment, they have a strong resistance to opioids in general. They're feeling really good for about 3 months. So even if we stabilize them completely off of the SR and then can use lower doses of Ibogaine to kind of reoptimize the opioid receptors, it's still helpful to take to load them up so that they have a large amount of noribogaine in their system because that window of 3 months they feel really good and they're not as likely to go back. Although at the end of that period, sometimes it can be a little bit disorienting to people because, for 1, 2, 3 months they're feeling great, and then after that 3 month window, they don't have that support on a neurological level in their body anymore. And so I know that we often like let people know to kind of expect that they that okay, at some point you don't have this crutch anymore of the noribogaine in your system, and then it really is up to you. So hopefully you've changed your patterns during that time and changed the people that you're around, change your home situation because at some point, 6 months later, a year later, the same stresses of life are adding up, and there may be a temptation to self-medicate if you haven't successfully created new, healthier patterns. So that the SR is really helpful, and it's really brand new in this space and relevant to the opioid detox use of Ibogaine.
How does someone get it?
Well, it's not a regulated substance in the US currently. Um, it is patented, and so people are mostly getting it kind of underground within the U.S., but there are various sources where the clinics have access to reputable, tested, supply of SR, and there's protocols available. There's large groups of people working on it underground, even without the Ibogaine, and successfully treating thousands and thousands of people with opioid use disorder.
Hmm.
So I think, someone in this group who knows a lot about that. I don't know if he's on here, but maybe Reed, if you felt like jumping in, if you're here. No, maybe he's not here right now.
I could speak to it a little bit too, Ian. I know
Okay.
some limited information. You probably know more than I, and Reed, if he's here, probably knows a lot more than I. But I just break in here real quick and say that I've been working in a similar way to Tobias, where when people come out of treatment, if they're looking for boosters or more integrative care and are looking to do detox with low doses. That's been something that I've been helping people work through for a really long time. And now, more recently, with the kind of popular or availability of the SR, we've worked with people through the addiction with the SR or worked carefully with the SR to taper. That's in the case of long-acting opiates and more synthetic derivative opiates. And that's been kind of mixed success so far. And then that segues into using the iboga, either the total spectrum or the PTA extract, for the kind of reset and the I guess it's kind of effects against addiction and the neuroplasticity, that 3 months of time to change your reality, to change your planning. But I think what I keep seeing time and time again is that people have access to these things. The SR project is one place that I don't know if they're still shipping to people, But yeah, people were able to order SR, and I think it's great that people had access because it's helped people off of a lot of dangerous, other dangerous substances in a way that I think is pretty novel and pretty amazing. But then, yeah, it's then incorporating that and incorporating the things that are great about Iboga to work with that. I actually know one of the gentlemen that manufactures a large amount of the 7OH extract in the States that goes out to the people in that country. And it's a really, really difficult thing to get off of. And I think it's kind of almost intentional. And by design, that maybe the addictive parts of the kratom plant have been hyper purified. So it's a big issue. How do we deal with this? How do we deal with essentially what I would consider in some ways the weaponization of these plant medicines against people and, trying to skirt regulation and all of that stuff? Well, I think you have all these tools that are coming out now, SR and other things that are becoming more available. And I think people should, in a safe way, be empowered to learn and work with them. Yeah, it's hard when we don't have a lot of protocol around these things. It reminds me of the early days in Iboga, when we were all kind of still figuring things out. And I think that's where we are. But I certainly see that the direction that things are going is towards the use of multiple substances in recovery. I think the Iboga has been touted as this, miracle for detox. I don't think it's that. I think it's a miracle for integration. I think it's a miracle for redirectionalizing energy. And I think we'll figure that out in time if we stay the course. But I'll open it to what other people think. And I have some limited experience, but I'm sure others do too.
I'd like to thank you so much, Evan, and thank you, Ian, for the SR information. I'd like to invite Anders to talk about preparing for the readiness for Ibogaine. What makes you ready for an Ibogaine journey and the preparation and integration? We're going to go into that more length later, but Anders, can you introduce yourself and talk about it a bit? Because like many people are complaining, it is not a magic bullet, and to give someone the impression that it's a one and done type of thing is misleading. And one of our intents here is to redirect people's understanding of what it is.
Hello, can you hear me?
Yes.
Yep. Okay, great. Wow. Yeah, I mean, I've been working. Well, my own journey into the world of Ibogaine was because I was in addiction, and the gentleman who gave me Ibogaine to begin with cancelled my treatment with 24 hours to go because he didn't feel that I was ready for it. And for the first time in my life, after having thrown a phone across the room and smashed it against the wall and wailed and cried like a baby, I thought to myself, well, what am I not bringing to this paradigm? And the reality is that at the end of the day, if people want to have a successful Ibogaine treatment, they're not going to the Ibogaine with an expectation that it's going to turn them into George Clooney or the Dalai Lama or the Second Coming. Ibogaine doesn't work like that. Ibogaine works in a way that if you get into the headspace where you want to heal yourself with the help of Ibogaine, that's when it starts working. If you go in there with the expectation that Ibogaine is going to be the magic panacea and the magic bullet, then you're going to be sadly disappointed more often than not. And so over the years, we've worked out that really, if people can put some respect and reverence and some intentionality and some tenacity and profound curiosity into the process of preparing for Ibogaine and meeting the Ibogaine, and a willingness to look at the core trauma behind their pain, then the medicine works in an extraordinary way. Young Pueblo puts it beautifully. He says, the only thing I was ever truly addicted to was filling the void I felt in my chest with anything other than self-love. And so the question for me is not why the addiction, but why the void, why the loss, why the pain? And if we can start to deal with those processes and those thinkings and those drives before you go in and do Ibogaine, it really helps. Well, I suppose the Ibogaine works with you. Ibogaine is a detox, but it's also a detox which gives you the opportunity to work on yourself. And we've noticed over the years that when people lean into the experience rather than just turn up, there's a profound difference in the efficacy of that Ibogaine experience. And also, I think what's really important to talk about is that we're living in a paradigm at the moment where the language tends to be take a plant medicine and integrate. Um, you know, 60, in the 1960s, Leary said set and setting. Go to the right place and get into the right headspace to do that. At the moment, there seems to be a lot of talking about just turn up and then integrate after. Decent pre-treatment informs whether your Ibogaine experience and whether your integration is going to be proactive or reactive. You're doing the work beforehand. You're setting yourself up for the work. And there's another thing I've noticed, and I think I'll end on this because I mean it's such a huge subject. But another thing I've noticed over the years is that the amount of respect and reverence, tenacity, intentionality, and curiosity you put into the process of preparing for Ibogaine is where the Ibogaine invariably meets you. It's a two-way street. It's a relationship with the medicine. People who tend to have bad experiences with Ibogaine, they go in because they go in with a sense of entitlement. They go in with a sense of arrogance. They go in with a sense that this medicine has to cure them and they're paying money to be cured and that's what they expect. And it really isn't about that. Pre-treatment and integration is about turning up for yourself, taking an interest in yourself, taking an interest in the conditioned narratives behind your trauma, whether that's familial, cultural, societal, educational, or religious, in some sort of way. Most people, everybody who turns up and does this work, the reality is that they are using drugs or they've joined the military or whatever because they're running away from themselves. And why are they running away from themselves? Because at some level during their formative years, they weren't seen and they weren't heard and they weren't acknowledged and they weren't respected by either the institutions who needed to protect them or their own family. And we can go back to something we were talking about with the veterans earlier, but if the client can turn up and have respect and reverence and intentionality and integrity for the process, they're actually putting it into themselves as well for the first time, perhaps for a long time. And this is where the difference is. It's a difference between expecting Ibogaine to heal you or deciding to heal yourself with the help of Ibogaine. And if you decide to heal yourself with the help of Ibogaine, it requires work and it requires curiosity. And that's where, people like I and many others come in and help the client understand their childhood trauma, understand the conditioned narratives that have put them into a place where they're feeling tremendously inauthentic. I always say that, Ibogaine kind of allows you to become the person you were supposed to be before the world got its hands on you. And I also look at addiction in this really very, very simple way, but I think there's a lot of truth behind it. That, addiction is no more than self-medicating against a profound sense of inauthenticity. Let's find out why you're inauthentic before you go in and do Ibogaine. So you've got the tools to be able to integrate and run with it after. I feel like I've been all over the shop explaining that, and I hope it's made sense in some way, but I think that's my 2 pennies worth for today. Thank you very much.
Thank you,
Well,
Anders.
I just wanted to add that, I really enjoyed your writing the other day, Anders, and you mentioned the stratification of
Mm-hmm.
Iboga and Ibogaine treatments, and I thought that was really astute. because there's a mixed bag of what's happening in the United States and like the Americans for Ibogaine and all this stuff. And I'm not here to criticize or endorse, but it does represent the beginning of the potential for like the industrialization or the pharmaceuticalization of these products or these medicines. And what you're talking about, is just like it's such a more holistic approach and it requires like experience. And so I just hope that those of us, such as yourself, that are, elders in this space and that have these insights, that these are actually taken seriously. Because if it is just turned into a pressed pill and a tablet and, just
Yeah,
another
absolutely.
drug, then something is going to be majorly missing from all of this.
It'd be a
So I just
disaster.
keep writing, please.
I, I see this very much, and I see this, and I see that there's some very, very, very large clinics at the moment. I won't name on here, but I think it's unfair. And what you've got is many of these clinics are working with maybe 100 to 150 clients a month, um, and it's a sausage factory. And yes, there is great medical oversight in these clinics more often than not, but the relational holding for these people is sadly missing. The reality is that if people want to heal, they need to be in an environment where they are seen, heard, acknowledged, and respected. They need to be in an environment where they feel that they can let themselves go appropriately, or be very curious about what's coming up in a very, very, very safe environment. Um, there's a couple of guys, there's Barry and Gareth who work in this field at the moment, and many others who work in a low throughput, highly relational um, paradigm. And the difference between clients who go through that process, having done pre-treatment, and then that really well held Ibogaine provision where the client just feels safe. They feel seen and they feel heard and they feel acknowledged and they feel respected. That's when the magic occurs. Because if we think about it, if the precursor for addiction and complex post-traumatic stress disorder is not being seen and not being heard and not being respected and adapting to those, that's where the inauthenticity starts from. So surely the only way that we can start to help these people heal is to present a place where they can feel seen, heard, and respected. And that to me has to be where the Ibogaine industry goes if we want to be serving the medicine and the individuals properly. So I'm hoping that if Americans for Ibogaine, get through and they do what they do, my hope for them is it's not going to be these super clinics which are pushing thousands of people through a year. What I would prefer to see is 30 or 40 different licensed clinics within North America who maybe only work with 10 to 15 clients a month. And so they can afford to give that relational paradigm to the Ibogaine healing. I think that's where that's where the magic is.
And
Yeah.
like you said, there's a stratification. Probably we'll see
Yeah,
both of these things happening. And even these
yeah,
high throughput, there's probably going to be benefits and people that heal and stuff to an extent. I see Alina
yeah.
has her hand raised, so maybe she wants to chime in.
Hi, excuse me. Hi, everybody. Thank you so much for having this webinar and just sharing your wisdom and knowledge. Thank you for speaking on what you just did. I am one of the people who has actually been advocating and pushing for this movement in the state of Missouri. I have been working with Americans for Ibogaine, and I also have a background of working with sacred medicine. So one of my fears, which I like to lean into fears. I don't want to let that hold me back, but I want to be part of this movement in a mindful way, in a respectful way. And I can't help but think about how, if we do pass these bills that we're currently working on, what does that actually entail? How are we going to steward this medicine forward? And this is, part of the reasons why I'm listening to elders, because all of your voices really do matter in how we shape this movement together. And I can't help but think about how, medical marijuana was treated after it got legalized, and also the ketamine clinics. So I am afraid that Ibogaine will be put more into the same category as the ketamine clinics have been. And a lot of the people who are interested or have been working in ketamine clinics are now looking at this medicine. And how can we be the careful stewards of not allowing it to fall into that pathway? And I think you spoke a little bit on that already. But from the perspective of, okay, this is the reality that we're in, and it's getting closer. And different states are already passing bills. Texas has passed a bill. Mississippi has passed a bill. Utah has passed a bill. So we're looking at more states passing bills this year. And then here shortly, within a short period of time, probably within 2027, 2028, this might be a reality. And how can we be the good, mindful stewards of this while also honoring sacred reciprocity?
I would love to answer that question. It's been something that I've been thinking about because we created a mission on Awake to end addiction one Ibogaine treatment at a time, and with 80,000 people dying in 2024, and all the people who are suffering from their deaths, etc., it's a huge problem, as we know. It is a problem that has to scale. We have to find a scaled solution for it because we couldn't help all these people if we didn't do that. At the same time, we have to create a model that is not the hospital model. We have to educate people. And this is part of the reason why we put this event up, and we'll put more events up. We have to educate people about not necessarily the people who are doing the research, because that's going to take some years, but the people right now who are going to start looking for addiction or TBI solutions right now. As they heard of Ibogaine, they're out there looking. And I think this conversation about preparation and integration and creating programs where somebody can do a clinical treatment anywhere in a hospital, but then be able to bookend their program with a preparation and an integration component and long-term integration. So in order to provide a container for that, we've created awake.net, and we've created this platform with education and high-level information about entheogens, particularly Ibogaine. And so I think that's the only answer is education and communications about the various facets of psychedelic medicines, particularly Ibogaine. That's going to do that. As far as your question about sustainability and reciprocity, that's a loaded question. That's a loaded thing, the idea of sustainability and reciprocity. And I would love to hear from Chris Jenks about Wakanga, and how Wakanga and the manufacture of Wakanga can perhaps provide a large-scale solution for providing Ibogaine HCl to a lot of people without affecting the sustainability issues that the Gabonese have about people taking their sacred medicine. So can you speak to that a little bit? Is that a reasonable question for you?
Sure. Well, my work started around 1997 or so. Back when there wasn't a lot of, I guess the price of Ibogaine was very high and it wasn't very available. And so my work started with developing extraction for Iboga, so that was low tech. It didn't require a lot of training or sophisticated equipment to accomplish. And so that made what is known today as TA, or total alkaloid, from the Iboga shrub bark. But within a few years, I started to realize that the demand for Iboga would keep increasing, and since it grows slowly and it's not very widespread in Africa, and that it would, it was already considered endangered at the time when I started. And so I realized there needed to be another source of ibogaine. And I didn't discover this source. It's already been known to have come from the bark of Voacanga africana, but it comes indirectly because the bark doesn't contain much ibogaine. It contains voacangine, which is a related alkaloid. And it's much more difficult to get the ibogaine from the Voacanga bark because Voacangine is only a small portion of the alkaloids in the bark of the Voacanga tree, whereas in Iboga, it's the major alkaloid. And so all you have to do is separate it from the bark, or even take, that's why you're able to eat the bark itself. But the Voacanga needs a long enrichment process. And so it took a long time, but I developed another procedure to produce ibogaine from the bark using a low-tech process so that it too can be produced in a factory that doesn't require very high-tech equipment and doesn't require extensive training for the people to run the factory. Um, so that was pretty successful. My procedures are open source, so you can look those up. They're on puzzlepiece.org. Um, Anyway, as they said at the beginning of this meeting, the need now seems to be the analysis of the products that are available, whether it be iboga bark or alkaloid mixture or your white powder, to find out how much ibogaine is in it. I mean, that would be the most basic question to ask. But there's a lot more that could be analyzed to improve that. So I see that as the new frontier because the production of ibogaine is really there's no technical barriers anymore. It's just a matter of implementing what's known. So now we need to work on quality.
Right, right. Thank you. So do you, your process that you have, is it currently something that you can implement, or are you still researching it, or where is that at?
It's implemented in multiple places. It's been going for years, and I'm very pleased with that. I personally just work on process development. I don't run a factory or anything.
Okay. Great. Thank you, Chris. So we have about 20 minutes left. Does anybody have any questions?
Sorry to interrupt you. Does anyone have anything to talk about methamphetamine? That's a really huge problem, like in New Mexico, a lot of rural areas, and I feel like it's a somewhat different protocol than opioid, and has of relevance to veterans who are using stimulants in their combat deployments. Thanks.
I wish Rocky was here.
Yeah, if
Does
anyone
anyone?
was, sorry, go ahead.
All I can. There was an echo of someone, Barry, when Barry was talking, and I think all I remember when we were there was discussions about when Colorado first created its healing, the possibility of healing centers, that like it would depend. It depends, and that Dana Beal, for example, has done a lot of stuff with ACT UP and in like chemsec circles, and has friends who'll say to him, "Well, the methamphetamine protocol would require someone to take it every day so that they would have an aversion to using methamphetamine." And his contact was like, "Yeah, but then they can just stop." I'm going to put my cell phone mute again, but it just seems like it was a longer period of time. And I had referred earlier to a family member who had teratogenic effects when she was in womb from her mother's methamphetamine use. So it's an issue of maternal and child health, I think, that affects another population that's part of another vulnerable population where it's not their fault that they have issues. Thanks.
Does anyone want to respond to that?
I can respond to one aspect of it and not as a provider, but what I will say is that with amphetamine and also like cocaine and stimulant use, I think extra screening with heart cardiac screening is really necessary. Long-term cocaine use, for example, can have major cardiac effects. And there's various protocols to do the acute interruption of methamphetamine, which I don't think Ibogaine is suited for. So I think the idea is to get off the amphetamine for a period of time and to stabilize using other techniques. And then afterwards, the Iboga can really have a restorative effect on the dopaminergic neurons, which is the big damage that is caused. So if you use Ibogaine too quickly to methamphetamine use, I think during the treatment there tends to be a lot of like stimulation. People want to move around a lot and walk around, and it's just can be difficult. They can have a lot of anxiety. But if you can stabilize them first using other techniques, then you can repair the damage that's done and often address the psychospiritual causes. And maybe someone else has more to say about that than me.
Gareth, you worked with a lot of people with meth.
Some, but not a great deal. Sometimes it comes in as a poly drug use, but generally speaking, we don't get a lot of inquiries around that.
No.
Which I'm surprised about because it's so ubiquitous out there in the street level drug use. Yeah, we have worked, done treatments for methamphetamine, and again, there's been a bit of a washout period. It's not unusual for somebody to arrive at our place and still testing hot, even
It's
though they
hard to
said
get
they
off
haven't
of.
used it for a week, So, but I'm surprised how little we get in applications around methamphetamine and stuff. It's more Adderall use and stuff. So yeah.
I know that Dr. Bruno Rasmussen, Bruno in Brazil, he he gets mostly meth patients coming for Ibogaine treatments. So because meth is big there, so I know that it does work. And someone was asking about nicotine here, and it works for nicotine too. But
Yeah, we've had good results with methamphetamine, actually, this year. Yeah, it's been good. So,
I mean,
but
I
again,
think the most
it's a repeated use, a lot of getting a lot of Ibogaine into somebody and then setting them up with a tincture or boosters afterwards, which is super important. But I think that's super important with anybody that works with the medicine. So, yeah.
So we have 10 minutes about, and I would really love to address for people who are looking for Ibogaine providers out there, what should they be looking for? What should they watch out for? It is still a bit of a wild west out there, and I know Anders says there's only like 3 or 4 clinics that he'll send anyone to. I would love to leave people with some pointers.
can I interject? I'll post something that I wrote before, and I put on our Facebook page before, and on how to look for a provider. But I think the most important thing is that if you're looking for a provider and he goes beyond informed consent and form filling, and he's talking to the clients in the weeks before, so they know where they're ending up and they've built a relationship with them. If the provider is concerned whether you've done pre-treatment, whether you're doing a soft landing, whether there's integration, even if your bills have been paid, what is your support structure when you get home? That is a good provider. The provider, and I've had arguments with with certain doctors, one very famous doctor who said, well, my job is to just give the medicine and the client has to work it out themselves. I think that's kind of, not a great place to come in from. Um, when I did Ibogaine 10 years ago for my own addiction, and as I said, I went to a guy called Paul Featherston who was working at the time, and he had the decency to counsel my treatment because he didn't feel I was ready. And the reality is, and this is going back to the stimulant and cocaine thing, when I kind of grew up in my attachment to how I was going to do Ibogaine, I actually got on an aeroplane to Sweden for a month before I did Ibogaine because I didn't know where to buy coke and crack there. And that gave me that 1 month of being clean and really kind of saying to the spirit of Ibogaine or Iboga that I'm taking myself seriously and I'm taking this journey seriously. Um, and when we come back to pre-treatment, maybe that's the job, is that, good pre-treatment is to get a client out of a headspace of entitlement into a space of humility to meet the medicine. Um, I don't know where I was going there. I think I've gone off path, haven't I? But
Well, let me
um,
introduce Paul. He's here.
yeah, Paul.
Unless you were finishing, I
I
didn't
hope
mean.
Paul will say something because, yeah, he cancelled my treatment for 24 hours to go. And actually, I think really, having the balls to do that was the greatest gift he ever gave me. He essentially saved my life because my crack addiction at that time had gone beyond appalling. I mean, I got to a place where I hardly recognized myself anymore. Um, I had managed that 5 or 6 days that I needed to be clean to go to Paul, but he still didn't want to work with me. And thank God, because what he did was afford me the opportunity to step into my own healing. And for that, I am incredibly grateful.
Paul, would you like to introduce yourself briefly? And I think Anand has a question. I saw a big question there. I haven't forgotten.
Yeah, where's Paul?
Are you
Come on,
here?
Paul.
Well,
Polly!
he's right there, but maybe he's not there.
Unmute
Okay.
yourself, brother.
Yeah, he said hi in the chat, but Paul, do you want to jump in at all?
You
Oh,
don't
he
need
did
the
say
camera.
you have to unmute and turn on your video. You don't have to turn on your video, but it would be nice. Okay, well, while we're waiting for Paul, Anand has raised a question here in the chat. I don't know if someone can answer it. I certainly can't.
Yeah,
Oh,
I
and
just
just a
wanted
side
to,
note,
yeah, tell me, Ian.
Paul said no camera or audio. I just wanted to say that. So no Paul, so please.
Okay.
Paul, I
That's
can put you
Yeah.
on Facebook if you want to, or do you have no camera video at all? A messenger until you.
He said no camera or audio.
okay. So Anand has a question about pause. Do you want to read it out, Anand?
Yeah. I just wanted to raise this because I mean, it's a slightly controversial approach, but obviously this is probably the best group ever to discuss something like that. Um, I consulted an individual who had a really strong response to Ibogaine treatment and did a lot of the integration after his initial Ibogaine treatment for opioid dependency, and he stayed well for about 2 years and then relapsed. So he went back for Ibogaine treatment a second time, and he felt better, but he did achieve a complete reset, which is successful, of course. But he said he still didn't feel fully restored, and he ended up doing IV ketamine treatment in a clinical setting within the first 3 months, actually, post Ibogaine. And he said he felt even better than after the first time he did Ibogaine, in that his sleep and everything was restored much quicker. Whereas we know, a lot of people still, they have a lot of craving reduction, but they still experience insomnia issues within the first, month or two post Ibogaine treatment for opioid dependency. And I'm curious if there is this kind of neurobiological explanation for particularly for heavy opioid users, where it's not just opioid receptors that are affected, but there's significant effects to NMDA and GABA related dysregulation that can persist. And ketamine, obviously, we know helps repair and rebalance those pathways. And I don't know, maybe is there any legitimate role for this as part of a broader strategy, specifically for opioid dependency? Or if anyone has any experience with anyone doing this. I mean, this is obviously just one case, so I just wanted to share that and see if there was any thoughts.
Well, I just want to jump in and say that I think that there is definitely a role for that. It can be ideally, I think that we want to avoid it, and if it's not necessary, because there is a dark side to the ketamine treatments, there can be, but I certainly think there could be a lot of benefits on an individual case by case basis. Just speaking from my, limited knowledge in that.
I would completely agree with you there. I think that there is definitely a dark side for ketamine treatment, especially with the new addition with at-home self-use, with limited oversight and limited medical history being requested and just prescribed. I've seen it in people personally, so yeah, that's why I think it definitely in a clinical setting, but again to use with care. It was interesting to hear this personal account from someone, and I just wanted to see if there was anyone else that had similar experiences with patients.
It's kind of interesting that it's on the other side of Ibogaine rather than because people come to Ibogaine for ketamine addiction, like somebody saying here, Garrett saying. Um, I think a lot of it has to do with the provider and the ethics of the ketamine provider in not getting somebody addicted.
Yeah, and again, I want to emphasize that this was IV ketamine in a clinical setting that's dosed and monitored very accurately and medical grade, very different from street ketamine, which it can be a lot of different things. And the doses are just crazy for street ketamine, whereas in clinical settings, it's way more controlled. But again, all of these things still have that potential for misuse. Absolutely. So to be handled with care.
I don't want to be this.
Absolutely. And I
Sorry,
think
go
the
ahead.
other thing with ketamine is it's a dissociative. And the reality of doing Ibogaine is not to disassociate, is not to transcend the human experience, it's actually to return to the human experience in the best way that you possibly can, and to embrace life in its fullest, including a little bit of suffering.
And I completely agree with you there, and that's why I said I felt like it was very controversial. But the way he was
Yeah, no,
talking and the way he looked, and then I had the way he was kind of explaining it. I mean, it was
mm,
yes, maybe the experience itself was disassociative, but when I'm speaking with him, I mean, he seems very with it and kind of doing the right things for going in the spiritual direction and taking care of himself. So it's
I mean,
it's a very fine balance, and I
it,
think. Yeah.
a lot of it's about horses for courses anyway. And, look, he's found something that seems to have worked for him. I mean, it's not
Sure.
something I would necessarily recommend, but at least, and this is the really important thing, to a certain extent, he's taking authorship and sovereignty of the narrative of his recovery. So at some level, I kind of like that. But at another level, we've just got to be really, really, really careful that he's not kidding himself.
100% agree.
Yeah.
Thank you.
Well, I think we are at 2 minutes, and thank you very much, everyone. And we're going to meet again next Thursday. And I'm hoping that Dr. Deborah Mash will be here to talk about the brain and the mechanism of action on the brain. I don't know if anyone knows this, but she just got FDA approval for noribogaine research to go forward. So that's really big news for her and for us. Well, thank you very much, everyone. Gareth, Anders, Barry, everyone who participated. This was another fascinating conversation. I look forward to next week.
Thanks for putting this together, Lakshmi.
Thank you, Lakshmi.
Yeah.
You're welcome.
Thanks,
Thank
Lakshmi.
you so much, Lakshmi.
Thank you so much.
Ian, lovely to see you, man.
Thanks, Lakshmi.
Thanks, everybody.
Welcome. Thank you. My pleasure.
Bye, everyone.
Bye-bye.